I am Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you are listening to JAMA Plus AI Conversations. Today, I am joined by Dr. Fang Fang, Professor in the Institute of Environmental Medicine at the Karolinska Institutet. Welcome.
Thank you for the nice invitation.
Very welcome. I'm very happy to have this conversation with you. We've worked together in the past, and I've been always very interested in your research. And can you tell the audience a little bit about your overall area of research in epidemiology, and then especially in the areas of dementia and neurodegenerative diseases?
Yes, of course. I have been working during the past 20 years here in the Karolinska Institutet, focusing on etiology and prognostic indicators for various neurodegenerative diseases, including amyotrophic lateral sclerosis, Parkinson's disease, Alzheimer's disease, and other forms of dementia. In my research, we use data from large-scale studies in the Nordic countries, including population-based cohort studies, case control studies, clinical follow-up studies of specific patient groups, and of course our population health registries in the Nordic countries, but also in other countries beyond. So in my research, we try to integrate molecular biology techniques, informatics technologies like AI methods, into traditional epidemiological study design. And in terms of research topic, we are mostly interested in the role of whole body physiology in neurodegenerative disease. For instance, how do energy metabolism, the gut microbiome, immune responses interact with each other in modulating the risk and prognosis of neurodegenerative disease?
So there's so many questions to ask you about that. And one, we're based in the US, but obviously JAMA and the JAMA network is global. Can you tell me about these data sets that you use? It's very different than, in the US, where our data sets can be very siloed. So tell me the comprehensiveness kind of these data sets and the type of data sets that you use, for instance.
Yeah, I guess, the large-scale cohort case control studies, clinical follow-up studies of specific patient groups, and they are similar to whatever database you would have in the States and other parts of the world. However, the Nordic population and health registries, they are indeed of special trait because of one magic number, which is called personal identification number. This number is used broadly in different sectors of the society, and you are given when you are born, or you are given when you migrate into one of these countries. And this is used across the lifespan, since you were born until you die. Thanks to this, we can cross-link many different registries in these countries on individual level. Basically, you can know how a person was born, or even earlier, how the pregnancy of this person looked like for the mother. And you can know what happens during childhood, early adulthood, middle life, and late life. And in addition to individuals, you know the household, you know the familial linkage across individuals, so you can do family-based designs. And of course, in addition to medical information we have, which is often from specialist care, primary care, prescribed medication use, we also have a lot of social demographic information collected for these individuals, for individuals themselves, for the household, and for the neighborhood. So this is why many of these resources have been using a lot in epidemiological and actually also clinical studies to address different research questions related to health and illness in general.
I mean, I think that's so wonderful to be able to look at not just the overall life course, but then to look at, the family history, and then, as you said, social, contextual, or social determinants of health and those factors. I think that's very unique. And so how do you think that the new methods we're seeing in artificial intelligence is going to kind of help identify what factors are contributing to it? And being able to also, do you think it'll be able to help finally be able to connect different systems of the body? For instance, gut health. I find that extremely fascinating, how that can be related to neurodegenerative diseases.
Definitely. I'm thinking, as I hear you, you ask two questions. First is, what are the unique application of AI methods in Nordic countries with these special data sources that is quite different from elsewhere in the world. I think here, the Nordic large-scale databases, not only the registries, but also biobanks and cohorts, they can be of special useful for AI methods because of the size, because of the longitudinal nature of the data collection. Because AI is really good in taking care of high-dimensional multimodal data, and this is what we have. But traditional statistical models used in epidemiology cannot really leverage such large amount of information in an efficient way. And this is a unique combination, I think, between AI and Nordic data sources. And of course, given the possibility of, looking through a person's lifetime, well, I'm exaggerating a bit because of the limit of the coverage of the registries. We don't have lifetime registry for everyone, but for a large proportion of a person's lifetime, we do. And as you said, across different layers from a person to a household to a neighborhood and to a society. So this is something that AI can definitely leverage and take good use of, I think.
Yeah. So in terms of kind of the multimodal data, that we're kind of seeing out there, are you talking about, is that photographs? Are you talking about, video recordings, audio kind of recordings? What type of kind of health data do you see that you have that's all being integrated in?
The one good thing about Nordic countries is, the habit of storing stuff. So I was talking about the registration system that is, covering health, education, social security, many aspects. But in the healthcare sectors, a lot more data is collected. Clinical notes, imaging, pathological reports, the pathological images, we have a lot of those data that are already digitalized. So, of course, everything is not population-based or nationwide coverage here. However, if one day sort of accessibility problem is resolved, then all these data layers can contribute to a final building up of an AI model. But I think then this is not really very different from other settings in the world, because this will not be, as I said, not be nationwide and hopefully population-based still, but not really to a large scale as a population covering 20 million residents in the Nordic countries.
What do you see as the next phase of your research, and the next opportunities that AI is going to bring to that? Or what would you like to see in the next 5 years being done in your research area?
Definitely. I'm really looking forward to the methodological shifts that AI is bringing us. And as I said, we have loads of data. And as you say very correctly, even if we have certain data that is only available in 1 or 2 or 3 hospitals, the beauty of our system is that you can link this data to everything else. So, although you have collected specific data, let's say movement tracking for 6 months of someone, but then what happened before and after and what happened beyond these individuals, but in their families and so on. So I agree with you. So I'm really looking forward to implementation of sort of valid AI methods in these high quality data we have access to, and hopefully derive high quality conclusions that are generalizable to elsewhere. I mean, that we can discuss at length, I guess, whether or not, the socioeconomic context, cultural context of Nordic countries will be generalizable to other settings in the world. That we don't know, but at least in terms of validity within the target population of its original data source, then there we have less of a concern.
So what are the ethical issues that you see then with having these kind of, again, maybe these AI tools being able to, develop these methods, but only for this certain target kind of population? How do you think about that, and how do you prevent issues from occurring in the future?
Yeah, I guess different from like typical classical research project when you need the participation from volunteers, or whether they are patients or healthy individuals. I think AI methods developed based on these administrative database, whether it's nationwide or regional, has less ethical concerns because you don't have as strong selection force, and you more or less make sure, also thanks to the universal healthcare system here in Sweden and other Nordic countries, the presentation of a person to a healthcare sector is not really very much dependent of their socioeconomic or ethnic background. So here, I think the AI methods used to derive whatever prediction or classification models will not be as sensitive to those selection forces, and then will be more generalizable to the target population or source population, as we call it in epidemiology, in these countries. However, further extrapolation of results to other populations may be difficult.
And so, again, because it's very interesting what other countries are doing in order to ensure that AI is safe, how is Sweden approaching AI policy? And is it connected to the similar regulations that Europe is doing, or does it have its own? Can you talk a little bit about that for our audience?
That is out of my comfort zone, but what I know is, EU has been working on an so-called EU AI Act since a few years back, and tried to classify the risk of different AI applications. Whether if it's extremely high risk, then this has to be banned. If it's high risk, then this has to be regulated. If it's not these two categories, then you don't have to be regulated. And then from last year, there's a new thing called the European Health Data Space Regulations, and this is specifically made to share electronic health data across borders within the EU, including electronic health records data, which will be super useful for epidemiologic researchers here in Europe, so that you can, this is regulated, so you can have the possibility to share electronic health records data across borders. And Sweden is very much aligned with these EU mandates. And although, as many other aspects in EU, Sweden can have its national or domestic focus or alterations to those mandates. But AI application is extremely active in Sweden, especially in healthcare and imaging-based analysis like radiology and pathology records and so on. This is what is happening. I don't think we are identical to America. There are some things that are similar, but many things that are different, and I cannot speak for the US as much as you do.
I've seen Europe be very proactive in kind of these AI, safety regulations. I think both into the realm of like new types of generative AI, but also for things like even just data privacy, for instance, which I think is it's another topic area that is important, where who gets to have your data. It's much more restricted in Europe. For instance, being on social media, that data can't be shared with other companies, and it's very restricted. Here, it's not so much the case. So it's interesting to know how different that can be. And it'll be interesting to know in the future how that influences AI development and research. And so do you see this as really changing the foundational structure of your research in any way, shape, or form? Are there any fears that you have with it? Or are you excited about it?
No, I'm definitely excited. First of all, as I say, the efficiency of data analysis, that is really unprecedented. That is something that is not thinkable a few years back. And also come back to data privacy issues and regulations here in Europe, as you were talking about. Now we have this exciting federated learning thing that, made sure that you don't have to always transfer individual level data across borders, but rather sort of let AI do the work at individual sites and, sort of secondarily improve the performing of the AI models to be applicable to different sites in the end. And then, I'm learning this myself, but, this human twins or digital twin thing, apparently it's not only for individual persons, but also for populations. These things I think are very exciting for us who work on population medicine, because this will resolve a lot of barriers for cross-institution or cross-country sort of collaborations. And this is what we are doing a lot with other Nordic countries in terms of mental health, including neurodegenerative disease, both in drug repurposing analysis, taking advantage of large-scale nationwide EHR data to identify drugs that are used for other conditions but may be useful to prevent or so modulate disease progression for neurodegenerative disease. And that is great. And then I'm also excited a little bit about the new learning opportunities for next generation epidemiologists. And I guess, now with AI, a lot of methods are perhaps much more fastly spreading and, learned by people who's ready to learn. And this will be cool because otherwise, you have to read a textbook and you have to learn statistics in a different way. Finally, it's almost like my wish, I hope AI can help data collection. Data collection in most of the countries, including, especially in the Nordic countries, are extremely time-consuming and costly. I hope we will have paradigm shift by some novel and smart AI methods so that data will be collected in much larger scale, however still high quality. And the one fear I have is, usually when we do research, we have an hypothesis-driven approach. We have expert knowledge and, we have one unknown question we want to do research on. But now it's all data-driven, While it's exciting because we get to know a lot of unknowns, but it's also a bit scary, like who is there to control whether or not things are still relevant? That is the only worry that I have.
It is true. I said it in the last one, but it's Pandora's box has been opened. I think it's going to be difficult to be able to kind of backtrack anything. What's the uptake like in Sweden right now with your students, for instance, or at the Karolinska Institute in particular? Is everyone using it? And how do you deal with that? How is the Karolinska Institute implementing any protocols for generative AI, for instance, and student learning in this area?
Yeah, I mean, first of all, students are definitely using AI on day-to-day basis, and now people start to discuss about potential over-reliance on AI because what you worry is, you need a quality control on whatever AI provides you. And I guess for people at my age or even more senior, then we have accumulated enough knowledge to be able to judge whatever is delivered by AI. But for students, especially the younger students, I don't know if they have the capacity yet. And I have heard from teachers of master students and so on, people are not as keen on learning through classical lecture hall way of teaching. And, they are much more keen on learning from AI. And this is a problem. But even Karolinska Institutet is a medical university. We are very keen on integrating AI methods. And hopefully, we are aiming to become a leading institution in the world for AI-based medicine. And how successful we will be, we can see. But at least, with the unique data sources we have and the unique combination of KI, which is both a research institute and with a lot of hospital universities, I think the application of AI methods will have a special application here in Sweden. I just feel like, if for epidemiology, utilizing AI, we still have to remember the epidemiology basics, mostly for students. I mean, they will maybe relax a lot on this rigor-related problems, thinking AI can resolve all errors. Well, it's just like any statistical model. When the data is collected, it's a lot less efficient or even impossible to correct the bias that you created before the data was analyzed. So I think this is a thing maybe we have the responsibility to remind our students or ourselves that, AI does not resolve that problem for us.
Yes. But I also thought you said is that AI will help with the data collection part.
I hope so, yeah. But these things are different, Of course, we have to tell, then we have to design what data to collect and how to collect. And then AI can help with the how to collect, right?
Mm-hmm. Mm-hmm. Hopeful wish. Well, that's a good way to end the podcast, is this hopeful account that AI will solve a lot of these problems, which it can, and there's a hopefulness to it. And I think we all just understand that we also have to be cautious, as there's some things the AI can't do. There's going to be still missing populations, and we have to make sure that we don't exclude them.
Thank you. I agree.
I am Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and I've been speaking with Dr. Fang Fang. You can find a link to the article in this episode's description. And for more content like this, please visit our new JAMA Plus AI channel at jamaa.org. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Moreau at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.